Hi, this is Nick Williford and Manos Berlakis presenting case 198 for the Manual of Percutaneous Coronary Interventions. This is a case of a fairly uncommon coronary finding, which is a coronary fistula. The patient presented with chest discomfort and transient ST segment elevation on the EKG. When he came to our hospital, there was minimal ST changes in the precordial leads. This is the coronary angiogram. It was done through radial access, and because of issues with tortuosity in the subclavian, we had to use an R2P or radial to peripheral sheath. But what we're seeing here is the right coronary artery. That seems to be okay without any significant stenosis. And this is the left main. We also see good flow. There is a mild lesion, but no significant stenosis. However, we do see an extra structure that originates from the middle of the LAD and then seems to be draining into another structure, likely the pulmonary artery. And this is seen here in the arteriocaudal view. And this structure is likely a coronary fistula. We were debating whether the coronary fistula could have been responsible for the patient's presentations. However, it is unclear how would that be, because the fistula is something that someone is usually born with. And in this middle-aged gentleman, it is unlikely that this caused the chest discomfort. We then did an LV-gram to confirm on whether we had an anterior elevation, and we did not see any significant regional wall motion abnormalities with good left ventricular function. So we thought it was unlikely that the patient had an acute anterior ST elevation myocardial infarction. However, on later review of the aortogram, there's another finding that is very relevant. We see here that the aortic root is slightly dilated, and then there is contrast flow, but there's also some extra flow that is going backwards into the ascending aorta. And this is indicating aortic dissection. This is the coronary CT that demonstrates the aortic dissection from the ascending aorta, going down all the way in the abdominal aorta. You see the false lumen, but there is good flow into the renal arteries. And then it continues further down all the way into the left external iliac artery. Several lessons from this case. The first one is that in patients who have transient ST elevation chest pain but don't have significant coronary artery disease, aortic dissection should be in the differential. In this case, the presence of a coronary fistula to the pulmonary artery was actually distracting. It distracting us for focusing on what was eventually the diagnosis, which is the aortic dissection. And finally, a left ventriculogram or an aortogram can help make the diagnosis of aortic dissection. Thank you.